Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Thursday, February 3, 2022, and I want to welcome you to Facebook Live. As always, this is your chance to get your COVID questions answered directly. As you can see, as I promised on Tuesday, we have a special guest with us today. This is Stephanie Gretsch. She's one of our senior epidemiologists at the Chicago Department of Public Health, and she's here because she is in charge of the team that does what we call vaccine-preventable disease surveillance, which means she and her team always work on things like influenza and other diseases, especially respiratory diseases. Obviously, has been super involved with COVID, but we've gotten so many questions in from you about what comes next. You know, as we learn to sort of live with COVID, how do we monitor? You know, we were getting all these questions about, you're not counting every case. What is that going to mean? And so invited Stephanie on to help us understand that. Tell folks just a little bit about your background.
Yeah, so I'm as Dr. Arwady said, I'm a senior epidemiologist at the health department. I've been with CDPH for about 2 years, but I've been working in public health surveillance for almost 10 years now. And our team is primarily focused on, we're focused on vaccine preventable diseases, so measles, mumps, chickenpox, flu. We spend a lot of time and resources on our flu surveillance. And then also just monitoring vaccine uptake, especially for COVID, but for all other illnesses. So yeah, happy to be here.
Perfect, thanks. So just so you know, all the questions that you are always asking me about exactly what's happening with COVID vaccine numbers and boosters and where are they, this is your woman and her team who make that data, who pull it in and put it on the dashboard and make it available to everybody. So thank you for all of the work. We got a lot of behind the scenes folks who make all of the things that we like to look at available. As always, you can put your questions directly into the box below. You can also use the hashtag AskDrArwady on either Facebook or Twitter. And I'll tell you now, we're going to be more likely to take your questions if they're about things like data and long-term, how do we monitor diseases? Because that's going to be the focus of what we do today. But let's start with a quick look at our dashboard, chi.gov/COVID-. And if we pull it up here, boy, this news keeps looking good. We're now averaging 889 cases a day, still down 47% from the last week. And I love seeing that steep decline there. That's been consistently over the last 4 weeks. We've been dropping by about 40 to 50% a week. Really good to see. Hospitalizations also, still 93 Chicagoans newly every day being hospitalized with COVID on average. That's still high, but it has certainly come down again, about 41% from last week. We're still averaging 13 Chicagoans every day dying from COVID. Also very high, right? What is that? More than 90 a week we're averaging of COVID deaths. The great majority of those folks unvaccinated, but that is also down. Vaccinations, we're doing about 9,000 a day. We have passed the benchmark for 4.5 million vaccinations.
Exciting.
Yay, very exciting. And we're doing about 28,000 tests a day. Our positivity is at 4.1%, which is of course good, down from 6.9% and under the 5%. Positivity, again, mostly tells us, are we testing enough? And when we are under 5%, broadly we are testing enough. So let me pull up just a couple of other things to highlight some of the questions that we've been getting in. And then we're going to turn it to you, Stephanie, to talk a little bit about how we do flu. So first of all, yes, it is nearly all Omicron, 99.8% Omicron, 0.2% Delta. And because we got so many questions about the subvariant BA2 on Tuesday, if you've still got questions about that, I would refer you to the recording from Tuesday. But it does remain very uncommon still here in Chicago, although we expect to see the proportion increase. It's not clear there are major differences in outcomes. We're watching it really closely. We do see cases continue to increase in Denmark, where a lot of the cases are now that subvariant, BA.2, which remember is just a subvariant of Omicron. It's all Omicron. And the decrease has slowed in the UK, but in South Africa, where there's also quite a lot of B2, we've not really seen increased cases. So we're still watching. I thought I'd show you the latest. Here's the United Kingdom, and what you see is there was a very beautiful steep decline, just like we've seen in Chicago in terms of cases. And then just over the last week or so, that really has stabilized at a higher level. And is some of that BA2? Is that turning into severe disease? That's some of what is still being looked at. But overall, our data here continues to look very good. When we put it in our risk matrix, we are almost out of very high transmission. Look at that. Cases, I am hopeful if we keep seeing progress in the next day or two, we'll get from that red back down to that orange, which is still high per CDC and everybody else, but really good progress. And you see that our test positivity is all the way down in blue already. Lower transmission. Hospital beds are in orange, but making progress, heading toward yellow. Our ICU is already at yellow. Remember, we want to see all of these move toward blue or green. And if next week we're getting even closer there, like these are the metrics we're looking at. You want to chime in anything about that?
No, just that I think we're seeing really good progress across all of our metrics, which is really encouraging.
Exactly.
And they're all trending in the right direction.
They are all trending in the right direction. And the stuff we follow behind the scenes is too. So this is going pretty quickly. I know lots of people, when might we be able to take off masks? When might we be able to lift the vaccine requirement? Not next week, I will tell you that. But if we continue to see the drops like we've been dropping, it would not be that long from now, I think. And we will be making those decisions based on the same data that we have been all along, and it's part of a larger national conversation. Also really excited that almost 3/4 of Chicagoans 12 up are fully vaccinated. We talk a lot about the first doses, right? We lifted up that 80% of people over 5 have had that first dose. But also, it is important to get fully vaccinated, and we're just about to an important benchmark of 75% of those over 12 here on the right being fully vaccinated. I'd like to see that 5+ eligible also get up to at least 3/4. Across the country, we sort of look at 80% there as an ultimate goal, but making good progress. And the vaccination rates, we are approaching 50% of our 5 to 11-year-olds in Chicago that have gotten their first dose of COVID vaccine, well above the national average. Good to see. Remember, getting your kids vaccinated protects them, protects families. Also, when your child is vaccinated, you do not need to quarantine if there is a child in their classroom at school. And so it's also one of the most important things for helping not disrupt education and keep our schools as safe as they can be. We were getting a number of questions in about what is going on with COVID vaccine for kids under 5, and I just wanted to remind you that there's a number of steps here. So Pfizer filed its application on February 1st to the FDA. The FDA then looks at all of this data, and there is a planned meeting for February 15th of the FDA advisory panel. The FDA advisory panel will look at this. That's a public meeting. You're welcome to watch it, and they will vote. Then the FDA, if they vote yes, the FDA would have to authorize that. Secondly, the CDC takes a look, because the FDA basically says, does this vaccine or this medication, is it safe? Is it appropriate? Is it efficacious? And then the CDC actually makes the recommendations about which population should receive it and when. What indications is it for? How does it fit into other vaccine requirements? And so there's a CDC advisory panel, a CDC recommendation, and all of this has to happen before it would be available to the public. I anticipate, based on 5 to 11-year-olds, that this would take somewhere in the range of a month, but I want to be clear that if any of these did not happen, we actually would not have an available vaccine just yet. Anything you want to add there?
No, just that it's kind of going through the process.
It is.
And we'll see how things progress.
We'll see how things progress, and we will be bringing you the details of that data as it is becoming public, and make sure you understand what that looks like. And then finally, this weekend, Saturday and Sunday, we're at Truman on Saturday and Malcolm X on Sunday, 9 to 2. We have lots of availability still at these sites. Children, adults, boosters, sign up, walk in. We would love to get you vaccinated this weekend. And as always, chai.gov/COVIDvax or 312-746 4835. Give us a call. We will do whatever you need to help you figure out your COVID question, including setting up a vaccine appointment at your house free of charge, if that's going to be the easiest for you. I'm going to hand it now to you, Stephanie, just to talk a little bit about how we actually do influenza, flu surveillance in Chicago.
Yeah, so we wanted to talk about our flu surveillance in Chicago, and our approach for flu surveillance is a little bit different than what we do for other infectious diseases that we monitor at the health department. Normally we do a lot of case-based surveillance, so we're counting every single case of a disease.
Like tuberculosis.
Like tuberculosis, or like measles or mumps, salmonella. With flu, we take a little bit of a different approach, and we look at a variety of indicators to help understand what's going on with flu in Chicago and across the country and the world. So I want to just talk through a little bit about what are our objectives with flu, and then we'll walk through how we monitor different surveillance activities to meet those objectives. So the first thing we're trying to do is figure out when and where influenza activity is occurring. When does our flu season start? What parts of the country are impacted? What parts of Chicago are impacted? We're trying to determine what influenza viruses are circulating and detect changes in influenza viruses.
Which is, just to sort of put that in context for folks, we usually call it strains in influenza, but it's kind of like variants. It's how is the influenza virus itself changing.
Exactly, yes. And with this too, we're looking to see how are the strains that are circulating match the strains that were included in the vaccine, and just generally, flu is kind of constantly changing as it's circulating in the population, similar to COVID, and we want to have ways that we can detect those changes. We also want to make sure that we're measuring the burden of severe illness. So typically here we're focused on hospitalizations and deaths caused by influenza, and then also describe risk factors for severe disease. So who is being most impacted by these severe outcomes. And then finally, we want to provide guidance for managing outbreaks in high-risk settings. And here we're really focused on long-term care facilities, because we know that these are the places where we can see spread and also have these severe outcomes. So we're kind of monitoring that activity that's happening in those locations, extra carefully, so we can make sure to intervene and provide guidance. So first we'll kind of go through what do we do in Chicago to find out when and where influenza activity is occurring. We use 3 different surveillance streams to accomplish that.
And surveillance is just the fancy word for public health data, so we know what the baseline is, so you can see if something is rising above the baseline.
Exactly. So the first thing that we're doing is we're looking at outpatient illness surveillance. So these are things like you go to your doctor's office and you have a runny nose, a fever, sore throat. So these are kind of people that are presenting maybe with more mild illness, and they're going to their healthcare provider. And we have a network of providers. We have 30 providers in Chicago that are weekly sending us information about the number of people that are coming into their office, and then the percent of those people that have what we call influenza-like illness. And that means they have cough, fever, or sore throat. And we measure the percent of all visits that are due to influenza-like illness.
And we don't necessarily know that it's influenza.
Right.
It could be COVID, it could be RSV, it could be some other thing, but it gives us a sense of sort of respiratory virus circulation.
Exactly. How much kind of respiratory virus activity is happening right now. So that's one way that we're measuring kind of when activity is happening. Another way that we measure is we look at our emergency department data. And we do a lot of this with COVID as well. So people are probably familiar with the work that we do to monitor what's happening in our emergency departments. So we also, all of our emergency departments in Chicago, they're reporting their data into a national platform, and we look at that data to look at the percent of all emergency department visits that are, again, due to this influenza-like illness. And this also gives us a sense of how much activity is out in Chicago, when is it starting, and then the intensity of that activity.
And we don't have to know the name and the details of those people. We really look at it as a system overall.
Right, yep. We can monitor, the ages of people, so it can help us see, we're seeing a lot more of our emergency department visits amongst our older population are due to influenza-like activity, but we're not monitoring, specific names or individual cases and admissions. And then the last thing that we do is we do monitor some laboratory data. So we have about 6 or 7 laboratories in Chicago that are submitting their aggregated weekly testing data. So they tell us how many samples they tested for influenza, how many of them were positive, and then we can see, percent positivity. Again, similar to what we do for COVID, where we're monitoring, the number and percent of specimens that are positive for influenza. We also get a little information from our laboratories about the strain or subtype of influenza that they detected. And we call this sentinel laboratory surveillance because we're not getting this information for every laboratory, but a subset of our laboratories, and we track them over time, and this provides us with good information about trends that we're seeing. So we'll dive into some data about each of these different data streams that we monitor. So the first one is this outpatient surveillance. So this chart is showing you the percent of all outpatient visits, so like you go to your doctor's office, the percent of all visits that are due to this influenza-like activity. The red line that you see, this is our current year. That's what's happening right now. And then all the other lines in the background, these are prior seasons. So you can sort of see what's happening now in Chicago versus what we've seen in the past. And then we do have what we call the threshold value. And this is based on the percent of visits that are due to influenza-like activity in off-season times. So this gives us a sense of, are we seeing more activity than we would in the summer months when we don't see a lot of respiratory virus activity? So it gives us a good frame of reference about where we're at.
Yeah, and having a baseline is really important for all of these things. We know that there's a flu season every winter. We want to see how bad is that flu season, but if we see something ticking up at an unexpected time, that's the kind of thing we would do a lot more investigation on quickly. And moving ahead with COVID, it's the same sort of thing. As we learn more about what its seasonality may be, what the patterns may be, we determine baselines, and then behind the scenes, when we see us start to tick above a baseline, it triggers the need to do some more investigation.
Right, and then we can also look to see, is this does it appear to be a more severe season than we've seen in the past? So that's also a helpful frame of reference. So this is sort of our outpatient illness, where we can monitor maybe less severe disease. We also monitor something very similar, again, in our emergency department. So this chart is showing you the percent of all emergency department visits that were due to influenza-like illness. And again, that red line, that's showing you where we are this year. And then the other blue and green lines are showing you the trends that we've seen in years past. So this year we saw a little bit of an uptick in our activity at the end of kind of December, almost when we were just seeing Omicron sort of start surging in Chicago, and then a pretty dramatic decline. So we've seen our influenza activity decline a little bit. We thought we might have a little bit of a flu season this year, and things have really kind of died down once Omicron sort of took over, and people were taking mitigation measures. But this, again, is another way that we can monitor for activity, see when activity seems to be picking up in the year, monitor the intensity of it. And again, we have nice sort of a threshold baseline about when is this unusual or when is this elevated compared to times when we see respiratory viruses circulating. And we can also compare this to see from prior years, is this kind of a normal season, or is this a more severe season or a less severe season? We can also use our emergency department data to look at activity throughout Chicago and see if there's any areas of the city that appear to be having more activity than others. So these maps, I have two screenshots here. One is showing you on the left-hand side our latest week. So this is what we're seeing right now in Chicago. And then I just grabbed a week prior, earlier in December, so you can get a sense of what this looks like. But these different activity levels, these are also, we use a baseline. And our baseline is the activity that we see in sort of non-influenza weeks, so typically in the summertime. And the different activity levels tell you how elevated the activity in that zip code is compared to our baseline. So the darker red that you see, the more activity is happening amongst people that live in that zip code compared to our non-influenza weeks. So this is another way that we can monitor activity in Chicago and see if we have certain parts of the city that are being, impacted sooner or at different times. The last way that we're monitoring for detecting when and where influenza is happening is through this laboratory surveillance data that we get. And this is, we're monitoring our weekly positivity amongst these labs that are submitting data to us. And again, this also helps us detect when are we seeing an increase in activity and how intense is that activity. And we can, again, compare it to seasons prior. So here you can see, like in 2017 to 2018, a lot of our flu activity picked up mid-December. But we've had other years when flu activity starts later. So in 2018, the following year, in 2018 and 2019, it was sort of a slower start to the season.
And that's that light blue line where It kind of takes longer for it to peak.
Yep.
It's really remarkable, how low that red line is. I mean, we've all been amazed with COVID.
Yeah.
We've got this huge COVID surge and we just have seen so much less flu.
Yeah. And you can't even see on this screen, it's hard to see, but our line for 2020 to 2021, so last year, you don't even see it here because it's just on the ground on the chart. You can't even see
that's,
it.
And that's the masking, the distance, exactly. It was this remarkable thing to sort of see flu in total control, total control at a time when this other respiratory virus was going so badly. So it's been a really interesting time for flu surveillance overall.
It has. It has. So this laboratory data is another way that we can, again, monitor when does flu activity starting and how intense is it. So another one of our objectives is determining what influenza viruses are circulating and trying to detect changes in influenza viruses.
And this is super important for COVID and will continue to be.
Yeah. So we also can monitor, we can get some data on this from our Sentinel laboratory surveillance. So we get some information about subtypes of influenza that are being detected at our Chicago laboratories. There also is special surveillance for novel influenza A viruses. And these are infections that either are subtyped as non-human, so maybe they came from swine, like pigs or birds. These are kind of concerning strains, or those
that we see in a human.
Exactly. Or they're subtypes, they're strains that can't be subtyped at our standard laboratory, and so we want to send those on to CDC so they can further look at them and understand.
Could this be a brand new variant to be worried about?
Exactly.
Mm-hmm.
Right. And then the other thing that we contribute to in Chicago is we have laboratories that are submitting specimens down to CDC, and there they do more specialized testing to see how the current strains that are circulating and are related to the strains that were included in our flu vaccine. They also monitor for evolutionary changes to see how flu is kind of changing and evolving. Again, picking up these different mutations that may turn into be a new concerning strain. And they also test susceptibility to our antiviral agents, so our medications that we can use to treat someone for flu. So they do additional testing to make sure that those medications are still working against the strains that are circulating.
And that's kind of like what's happening right now. Every time there's a new variant of COVID, there's immediate testing against the existing vaccines, but then also they're looking at it against the new antivirals that we have for COVID.
Yeah, right, exactly. Very similar. So we'll get into a little bit of data that we used in those streams. So the first thing I wanted to show was how we're monitoring different subtypes of flu that are circulating. And these charts on the left, you can find them on our website. The top one is showing you what we're seeing this year in 2021 and 2022. We've seen a lot of influenza. We haven't seen a lot of flu yet, but we did have some flu activity that started sort of end of November into December. Mainly we've seen influenza A circulating, and the ones that we have had subtyped have been this H3N2. So that's what we're seeing this year. And then I wanted to show you that same chart, but for a different season, so you can see how this data looks historically. So this year, this season, 2017 to 2018, you can see in that kind of lighter mid-blue color, that's influenza A. So that's kind of what we saw earlier on in the season. And then it sort of shifted to be influenza B that was circulating later in the season.
And so that's kind of like, Delta earlier and then Omicron later.
Right,
It's the same idea.
Yeah, and so this data lets us see those shifts that are happening. So this type of work is also happening at the national level. So states and clinical laboratories, like our hospital laboratories, are also sending information down to CDC, and they can look at this across the country. So the chart on your right is showing you data that we're seeing nationwide about what is circulating this year in the country. And that red bar, that's influenza A, H2N3. So mainly we're seeing a lot of H2N3 this year. And then we also have some A that hasn't been subtyped. But predominantly this year we've got influenza A, H3N2. So that kind of is the picture that we get from this data. CDC also does some more sort of intensive laboratory data where they're doing additional characterization to understand the subtype that we're seeing, and then these different sublineages and clades.
And this is kind of like BA1, BA2,
Exactly.
BA3 of Omicron,
Yes,
actually.
Exactly.
Yeah.
Right. And so this information is used because it helps us, one, get a little more details about what exactly the more details about the strain that's circulating, but it's also used to understand if these strains that are circulating match what was included in our flu vaccine for this year.
Right.
And that gives us clues about how effective we think the vaccine is going to be, if when the vaccine is developed for the next year, what strains to include. So all this information is used really to monitor what's happening, but also monitor and make sure that our flu vaccine is matched and working. The other additional testing that's done down at CDC is this susceptibility testing. So this is really telling us, is this medication that we have to treat flu working against the current strain?
And this would be like a Tamiflu is the brand name that people
Yes,
probably know best. After you're infected, you take a medication that helps keep you out of the hospital, and this is exactly what is newly available. This idea is newly available for COVID, but it's really important to know how well that, just like we want to know how well the vaccine's working, we want to know how well the treatment's working.
Exactly, and if certain treatments aren't working, then we can tell our providers this medication doesn't appear to be working, and we want you to be using other medications if there's options.
Yeah, and so like in Omicron, we had 3, these were the IV versions. It's slightly different, but it's the same idea. 3 medications. 2 of them didn't work well for Omicron. The last thing you want to do is give people medicine that doesn't work. And so we work very fast on this, but we have ways to do it.
Yeah, exactly. So that's some other testing that we're doing for flu that's happening down at CDC. So another one of our really big objectives of flu is measuring the burden of severe illness caused by flu, and then describing who are the people that are getting sick with severe illness and what are some risk factors. So we use sort of two different streams to monitor that. One, we're monitoring intensive care unit hospitalization. So these are the people that are not only hospitalized, but they're sort of the sickest of the sick, and they're in the intensive care unit. So these are reportable in Illinois, so we hear about every single one of these. And then we also are monitoring mortality surveillance, so deaths that are happening due to influenza. And pediatric influenza-associated deaths are another reportable disease in Illinois, so we hear about every single one of these. And then we also use some death certificate data. to monitor the percent of all deaths that happen in Chicago that are either due to pneumonia or influenza.
And that's because influenza can turn into pneumonia.
Yes, and oftentimes, on the death certificate it may just say pneumonia, but influenza contributed. So we look at both so we have a good capture of what might be happening. And most recently, we've also expanded that definition to include COVID deaths as well, because all of our respiratory illnesses are sort of wrapped up together. They present very similarly.
And you only know for sure if you have a test result.
Exactly, right. So here's some information about what we've seen in terms of ICU hospitalizations. In Chicago, over our different flu seasons. We've had, generally we have around 200 to 300 ICU admissions, sometimes higher. We've had more severe seasons when we've had, over 580 ICU hospitalizations. But most recently, you can see in 2020 and 2021, and then this year we've had very few ICU hospitalizations.
It's just amazing to see.
Which is, it's pretty crazy.
Yeah.
And this is just because of the total lack of flu activity that we've had once COVID really took over. So this allows us to monitor sort of the intensity of the flu season, how severe a flu season is.
How much strain is there on the ICUs?
Exactly.
What do we need to do to kind of protect that capacity in the hospitals, all of that kind of stuff.
Right. So we also have a few other sort of data points around ICU that we include that's on our website. We look at ICU admissions by week for this season, which you can see on the right, but I also included some screenshots of past seasons so you can see how it's looked in the past. And you can explore all this on our website. And then we also monitor, the demographics and risk factors of people that are going into the ICU so we can understand who's being impacted.
And our COVID data and dashboard was built sort of right on the back of what we do here.
Exactly.
So,
Exactly. Yep. And then we're also looking closely at pediatric influenza-associated deaths. And fortunately, we haven't had very many pediatric-associated influenza deaths, but generally we've had at least one every year.
In Chicago.
Mm-hmm. But we haven't had any in the past last year, and none so far this year. But this again also helps us monitor for these severe outcomes. And then finally, we're looking just overall at the percent of all deaths that happened in Chicago and what percent of them were due to pneumonia, influenza, and now we include COVID in that definition as well. And you can see earlier on, when it was a severe flu season, we saw maybe around just under 9% of all deaths in Chicago were due to pneumonia and influenza.
So like on this graph there, that little red and blue line, that's sort of the season. That's winter, summer, is that right?
Yes, so the red is when we typically think about our flu season, which is October through May. And then the blue would be kind of the off season, so the summer months.
So in the years before here, somewhere between 6.7 and 8.6% of all the deaths in Chicago, is that right?
Yes.
Were from pneumonia, influenza.
Right.
We didn't have COVID at that point, but from one of those.
Exactly. And those would be like in our worst year in a really bad, severe flu season. We saw just under 9% of our deaths were due to pneumonia, influenza. Now with COVID,
This is also a shocking graph for epidemiologists.
Yeah, I mean it's pretty crazy. Almost half of our deaths during that initial wave in the city were due to pneumonia, influenza, or COVID. And we've seen that, you can see that second wave when it got down to about 34%. And now we're sort of, again, back up in this Omicron wave.
And this is, for me, we get a lot of people commenting, COVID's just like the flu.
Yeah.
I wish COVID were just like the flu, because the flu looks like everything on the left and COVID looks like the right. And the good news is, as vaccines have become available for folks who are vaccinated, it does come more back down to look kind of like the flu. But unfortunately, we have seen a lot of, and these are deaths, and deaths are the best data we've got in a lot of ways.
Right. Yeah. So the final thing that our final objective is we want to make sure that we can provide guidance to manage outbreaks in high-risk settings. And with influenza, we're most focused on long-term care settings because we know these are settings where flu can spread easily, just like COVID can spread easily in these settings. And this is also areas where we can have these severe outcomes, these ICU admissions, these deaths due to influenza. So outbreaks of influenza in long-term care settings are reportable in Illinois. So, our long-term care facilities, we've been working with them.
Meaning by law, they have to
they need to
report
tell
them.
us if they have 2 or more people that have tested positive for flu within 72 hours of each other. So we're monitoring for that. And when that happens, then we can, connect them with making sure they have the latest guidance. We can provide them with infection prevention resources. We'll make sure that recommendations around doing antiviral treatment is there. You can also do sort of preventative treatment for people who might have been exposed. So we want to make sure that that medication is being provided and given to the residents in the facility. So that's one way we do stuff. And then newly, we're also we're getting data around COVID and influenza positive test results in long-term care facilities through a new sort of CDC reporting mechanism as well. So we're monitoring both data streams to make sure that we're capturing the sort of full picture of what's happening in our long-term care facilities. So the kind of final slide I have for everyone is this is showing reported long-term care facility influenza outbreaks by year. The gray bar is showing you what we're seeing in Illinois, and then the red bar is showing you outbreaks in our Chicago facilities. So in kind of a bad year, this 2017-2018 year, we saw 21 outbreaks.
And then the health department is sort of responding around those.
Exactly. So we're following up and making sure that, again, they have the latest guidance and we're tracking what's happening.
All right, perfect. So thank you. Obviously, that was a lot of data for our folks here, and those of you who like the science and the data, I'm sure are happy. And those of you who are like, I just want my questions answered, are like, why have we been talking so long? But I thought it was really important to actually go through in some detail because this is what we're going to be. Some version of this is what long-term monitoring of COVID is going to look like. Let's kind of get into some of your questions about that. So I'm going to start right off with, Aaron Hoffman on Facebook right away. How bad has the flu season been this year in Chicago? And we haven't heard much about it. And you addressed this, but just very briefly.
Yeah, so we have seen some flu activity this year, more than we saw in the year before, but generally flu has been mild. But we're monitoring very closely to see if activity picks up, especially as Omicron starts waning.
Good. And then Mary Rodriguez on Facebook. With lower levels of circulating flu variants, are there any scenarios in which the flu could end circulating? Or are there too many variants? And she says she's curious how the coronavirus may look in the future if it may become more of an annual concern. And I will just preface this by saying, I like it when people are thinking like this. I'm curious what you have to say.
Yeah. So I think flu will always be circulating, and it's
Agreed.
not something that we can get rid of.
Agreed.
It's kind of always going to be, even in the summer months, flu is kind of there at low levels. We, of course, also, we live up in the northern hemisphere, and our flu season is sort of this October through May. Down in the southern hemisphere, like Australia, South America, their flu season is actually our summertime. So worldwide, flu is kind of constantly circulating year-round. So it's here to stay.
I agree. I think if we lived in a world where there was no travel, there was no intermixing, there was no, we had a little wall around Chicago. Frankly, one of the reasons why flu surveillance, and this is getting in a few of your questions, why we do flu differently than tuberculosis, where we count every single case, is that there just typically is a lot of flu, and you're not going to eradicate it. Like, you're just not.
Right.
You want to make sure you're acting quickly to control the highest risk situations, make sure people are connected to vaccines and to preventable medications. But frankly, if flu looked like it did these last 2 years, with 1 and 2 cases, we would, you'd do this super intensive, could we possibly eliminate it? But in the world of influenza, no. And it's been with us for,
I mean, hundreds.
Hundreds of years. And it also, there are animal reservoirs as well.
Exactly.
And, there's a number of things that go along with this. So, but that's a really good question. Yeah. Mary Rodriguez from Facebook says, at what point would we consider the pandemic, meaning COVID, to shift to endemic? It seems like where people are vaccinated or recently infected, the new variant symptoms are milder. I understand it's still not great for unvaccinated. There are some better treatments available if taken early. Yeah, very good. So, do you have an opinion on that? And then I'll chime in. When do you think we might consider this endemic? And this is going to be an opinion, just to.
Yeah. I think we're very close to. I think we might be there in considering that COVID is endemic.
And what does endemic mean?
Endemic means that COVID is just going to be circulating sort of all the time. I think early on when we first detected COVID, there was a lot of hope that we could contain the spread of COVID, similar to how we've done with SARS or other infectious diseases that were introduced. Our first response always as public health is, how can we contain this?
And try to get to a point where it's zero. That is always the initial goal. And with, people may not know this, the two most recent coronavirus outbreaks, which was MERS, Middle East Respiratory Syndrome, and SARS, Severe Acute Respiratory Syndrome, which have all been just in the last, 10, 15, 20 years. Both of those were coronaviruses, and both of those, with a lot of very intensive case investigation, contact tracing, et cetera, we were able to get down to a point where they didn't become a major problem. But partly because this one spreads so much before people know they have symptoms.
Yeah. And just so, even when people are symptomatic, it's very, very
very infectious, yeah. So yeah, I would agree. I mean, endemic basically means it's the difference between endemic. Endemic is like it's always here at a level. Right. Epidemic is like it's above the level that you would sort of expect. So endemic doesn't mean anything about whether something is mild or not. It just means whether it's kind of here to stay. Okay. So Megan from Twitter says, do we have an idea of when the COVID season is? We've surged at different times of the year. Again, this is sort of an opinion question, and you can answer it and then I will.
Yeah, I mean, I don't think we know quite yet what the COVID season is because we haven't had a normal year of COVID transmission. We've had all of these introductions of these various variants that really are disrupting our normal patterns. So I think that's still to be learned as we move forward with this. I think there is the potential that it may act sort of similar to flu, where it's more sort of winter focused. Our past 2 summers in Chicago have been very well, but it also sort of aligned where we haven't had this new introduction in the summertime. So I think we don't know yet, but we'll kind of learn more as things stabilize out.
Yeah, and I would say sort of in this best case scenario, off kind of Mary's question before that, in an ideal situation, and I know there are people who sort of are crossing their fingers, this could be more true. Omicron has been so infectious that it really outcompetes other things, and we sort of could settle down where Omicron is what we are seeing in a long, and there's some chance for it to settle into seasonality. But we have seen COVID lots of times not settle, right? And it is premature to sort of say Omicron's, the last variant or the one that's milder. I mean, that would be wonderful. But what we have seen is all over the world, every 3 months or so, a new variant. And that has not been, in a variant that sort of causes an increase and changes. And slowing down how quickly those variants are coming and emerging is critical for staying ahead of any of this. And we keep that down by limiting spread.
Right.
Okay. Jen D on Facebook says, I've heard that states are being told to start wrapping up contact tracing efforts. How are we going to know about variants and all of the other data without tracing? So maybe I'll start with that, and then if you want to chime in. So in terms of wrapping up contact tracing, really how we are thinking of this is that in the same way we have never counted every single case of COVID, we also have never finished a case investigation for every case of COVID or contacted every contact. Not because we don't have a robust program, but because this is voluntary in the US. It depends on whether people want to talk to us when we call, when we follow up. There are some settings like schools where it is quite easier to determine contacts. And so we do a lot of, one of the jobs of epidemiologists is to sort of look at patterns of disease, knowing that individuals will behave differently. But so really this is about not contact tracing everybody, every single case. For tuberculosis, where we have 100 and something new cases in a year, yeah, we contact trace excessively every single case. But here it's more about where are the high risk settings, where are the outbreaks, where are the places that we really need to put more efforts. And then, but then to the second part of the question, so if we're not counting them, how do we know about variants? And you addressed some of this, but
yeah. So, we use a lot of our other data to monitor for variants. So we're really looking at our laboratory data and testing around that to see what variants are circulating. We can use all these other indicators to see what's circulating, and then risk factors. And then we still always have the option to talk to people to understand what's happening, but we don't need to talk to everyone to understand risk factors for disease.
Yeah, and behind the scenes, like if you've been following along with this, some of the other epidemiologists that I've had on with me are some of the folks at CDPH who are focused on testing and laboratory-based surveillance or data, and that is an area we've really been able to grow with new federal funding from COVID. And so, for a long time, as you heard, we've been collecting influenza samples from different labs, and we do some basic testing, and then we sort of send them down to CDC if they need a lot more investigation. We have now built up more capacity right in the city to be able to do some of that more advanced genetic fingerprinting. There are other labs that are doing this. It's been a big investment and a needed investment, I think, across the whole U.S. Right. But we are very interested in being able to do some more of that. Now, remember, when we're doing that, it's more to understand what is happening in patterns of disease, but we want to make sure we're getting that from different parts of the city. We want to make sure always, and we do this right now, that if we are seeing breakthroughs in a way that would be unexpected, if we're seeing people who we might not, somebody with no underlying diseases and young and healthy getting seriously ill, we would potentially be more interested in taking the genetic fingerprint of that person's COVID. And even in a long-term way, having some of these signals to say, let's make sure there's nothing on the virus changing side that we need to be aware of. And so we've built up a lot more protocols to do that, and the ability to collect samples from all over the city, even places that don't have the advanced labs. Right. So,
and none of that is going away. That's all
right.
Staying.
This is exactly.
And even expanding.
It is expanding, and not just for COVID. Like, this is the idea that, like, understanding sort of how we coexist with viruses and bacteria and being as prepared as we can be and monitoring for trouble is a huge part of being prepared as a city and as a country. Yeah. Interesting question. Maggie K9 from Facebook says, this is very big picture. Do you think there's a relationship between respiratory viruses and climate change? So again, this is opinion. Relationship between respiratory viruses and climate change. What do you think?
Yeah, that's a really interesting question. I think we think about climate change in a number of different ways. One, it's changing behavior and what humans are doing. But it's also changing, potentially changing our environment. It's changing our environment. It's changing how animals are interacting, how we're interacting with animals in our environment. I don't think we have any, sort of definitive answers around how that may be impacting circulating strains. So I don't think we have good answers yet. But I think,
Yeah, we've seen pretty more clear impacts of climate change on things like tick-borne diseases, where we think about where we see, diseases that are spread by mosquitoes or spread by ticks. As the climate changes, you see mosquitoes in parts of the world carrying diseases that weren't there before, or ticks in different parts of the world. As we change, with climate, as we change habitat, trees, et cetera, you will often see different patterns of how animals and humans may be interacting, and that can be a risk factor. But we're still learning a lot about this, and we we know that there is seasonality to all of these viruses. Most of these viruses, many of these viruses have seasonality. And as the seasons themselves change, almost by definition, that will change how the respiratory viruses may surge and come down. But the jury is still out, I would say, in terms of all of the directions in which this will move. Yeah. All right. Okay. We got a couple of questions here. Becca Wood on Facebook and Alexandria Dion on Facebook asking similar versions of, why do some people get COVID while others don't? Some people are calling the group a never COVID cohort. That's very interesting. So, and then Alexandra Dion is saying, is it possible there's a reason why some people just don't get COVID and others do, besides vaccination, obviously, some sort of natural immunity? So, do you have any thoughts about that? This is really getting outside of your area of expertise, but I know you spend a lot of time thinking about this, and I'll chime in too.
I mean, I think, no infectious disease infects everyone 100%.
That's right.
So there's always going to, potentially some underlying immunity, some maybe past exposure you have that might be protecting you. Maybe these people were infected and they didn't know it.
Yeah,
they were infected.
I think that's a big one.
They were infected, but they were asymptomatic and they didn't get tested and they didn't know it. And so now they have a little bit of underlying immunity as well. So yeah, interested in your thoughts on that.
Yeah, and I would add, so this is one of the questions that scientists are, of course, the most interested in. For me, in terms of some of the things that I would, nobody asked this, but it's related. Things that I would most like to know from the scientists who are studying all of this. Number one, I would love to have a blood test that tells me on an individual level whether somebody is protected enough against COVID. We have that for measles. We call it a titer. You can take a blood test, and on an individual level, you can say chances are pretty good you've got enough protection. Or if you take the titer and it's negative, let's make sure you get vaccinated or a booster, really quick. We don't, though, have titers for things like influenza, and that has to do with different strains and the way it works, et cetera. But it would be amazing to have a simple test that tells me I have to be worried about, imagine, I'm protected, and never 100%, but I'm 99% protected. We don't have that. An antibody test, I know people try to use it like that. It doesn't tell you whether or not you have full protection. I would love to have that. The other thing is, can we have some actual tests that tell you more about who's at high risk of getting sick? We've learned a lot about immunity, but there is a lot we still don't know. And when I say immunity, I don't just mean COVID immunity. I mean how different people's immune systems work. So some of the most interesting basic science research that I'm keeping my eye on, there's 4 or 5 different kind of hypotheses of things you could maybe even measure in somebody's blood that might tell you this person is at higher risk for having a severe outcome from COVID. So, there's particular immune cells that might be at higher or lower levels. One of the scientific groups has a theory. There's a really common virus called Epstein-Barr virus that in people where it reactivates, something with their immune system, might there be an interaction? Is there underlying conditions? There's a suggestion certainly that diabetes seems to independently predict severe outcomes from COVID, even when you control for everything else. But understanding this question of why some people, and for me it's not get COVID, it's get seriously sick with COVID, and some don't. I don't think we have a never COVID cohort, but you never want to say never. I think if is it possible that there are people, and we've seen that with HIV and some other diseases, are there some things in people's genetic makeup that actually, it's an amazing clue if you can identify someone who doesn't seem to get infected with a disease. Let me tell you, there is a lot of work to understand what is different about that person, and could we copy that in some way to make a drug, to make a vaccine. So I think we're still learning, but we know the risk factors for getting seriously ill, obviously, age, not being vaccinated, never having seen COVID before, being in contact, with a lot of underlying health conditions, all of these sort of do fit together. We are just about at time. I am gonna though, I'm gonna take this last question. Liz from Twitter says, while I think COVID vaccine mandates have been unethical, I'd like to understand from a perspective of epidemiology, why has, quote, natural immunity been ignored? What do you think of CDC's recent statement recognizing its protection? So I'll handle some of this, but if you want to chime in on, from a perspective of epidemiology, how do we think about quote unquote natural immunity and give people some background on that, and then I'll maybe take on the rest of it?
Sure. So I think, the question is, and this is a big question that, scientists everywhere are trying to understand. What is the difference between natural immunity versus vaccine-induced immunity? And I think, there have been some very good studies that have shown that natural immunity is just a little bit more unpredictable than our vaccine-induced immunity. So it doesn't always, not everyone is protected as much as someone else. It might depend on how severely you got sick and what kind of antibody response or response that your body mounted when you got sick. So it's different from person to person, whereas our vaccine-induced immunity is very predictable generally. So we have just better predictable protection. But as there have been these new variants introduced, there's also some good evidence that prior immunity from, when you maybe got Delta or Alpha or one of our early strains of COVID is not protecting you as well against a new variant strain, whereas the vaccine seems to provide a little bit more predictable coverage, even from different strains. We are definitely seeing reduced effectiveness of the vaccine with Omicron, but it still does seem to be doing a very good job, particularly against the severe outcomes. So yeah, but I think, natural immunity certainly does provide some protection, but it's just generally not as reliable and not as, doesn't appear to be as stable, particularly when we think about these different variants.
Yeah, and I would just add, we don't have what we call sterilizing immunity for anything with COVID. Sterilizing immunity means I'm totally protected. Like, I'm not gonna get this, right? Assuming that the vaccine took or I really had the disease. Right. And there's always some amount of, quote, breakthrough from natural, breakthrough from vaccine-induced. And there's also differences in terms of longevity and, as you say, predictability. And so one of the things that has been really concerning is that in Omicron in particular, we really saw almost no protection against infection for people who were sort of depending on prior immunity, like really almost none. We also saw almost no protection against infection for folks who had just the one J&J, which is one of the reasons why the recommendation was to get the booster, especially for J&J. We saw decreased protection against infection for folks who had Pfizer or Moderna, but still about twice as good as people who were counting on prior immunity. And we saw with a booster in the large studies, you could actually get that protection higher. And but then the big question for me is not just about infection, it's about those severe outcomes. And that's where I think we're still trying to tease a lot of this out. Did we see people get reinfected with COVID less than 3 months later? Yes, absolutely we did. Have we seen that all along? Absolutely we have. Are you less likely to get COVID in those 3 months after you've been infected? For sure you are. And if there isn't a new variant, and you've definitely had it and you had enough immune response, et cetera, you should be pretty protected in the short term. But I'm just gonna expound for a second. Yeah. Somebody asked me the other day, what are the two, when were you the most worried with something that you read about COVID, throughout all of this? And I will tell you, the 2 times I was the most worried about something I read, which is different than, I was worried about overwhelming the hospitals. I was worried about something practical on the ground here. In terms of the 2 times I was the most worried, number one was pretty early on in COVID, when we were still in sort of contain mode, and we were treating this like SARS, like MERS, like Ebola, where as long as you're doing a really good job of monitoring for symptoms and tracing everybody with symptoms and following them up, you've got everybody. There was this really early study that was actually out of Germany that described a woman who had traveled from China, so that made sense because we were in containment mode, and she hadn't had symptoms but had maybe spread COVID in Germany. And everybody was like, whoa, like, did that really happen? And it's interesting because there was a lot of, the immediate push was to be like, I bet she really had symptoms. And actually they went back and maybe there was a language thing and maybe she had, and I remember being like, okay, maybe she had mild symptoms at least, but it was like, right then, early on, if this is something that people can spread before they know it, it's in a whole different category. So that was one. But do you know what the other one was, for me anyway? And I've talked about this a little bit before. There's this city in Brazil called Manaus. I didn't know anything about Manaus prior to COVID, but it had a terrible COVID outbreak early, pre-vaccine, 2020, like one of the biggest, worst outbreaks. Overwhelmed the hospitals, mass graves, like huge death rates, like everybody in Manaus got COVID, is really what the scientists thought. And there was really this assessment, and it was in Science, which is the very best science. It's like the best journal out there is the one called Science. It's the hardest one. It's like the best published, the best thinkers in science will get their work there. And there was a study in there that basically said, okay, this isn't the way we want to do it, but Manaus probably has, quote, herd immunity, probably has natural immunity, right? And like, we got to pay attention. I mean, it didn't say it exactly in those words, but reading between the lines, it was this sense like, my God, that is terrible. And we got to do everything we can to not let that happen. But on the other hand, Manaus shows us the pathway maybe of natural immunity. And then do you know what happened? Like a few months later, again, pre-vaccine, here came a new variant, and it was a variant, I don't remember which one it was at this point, but it was one of the ones that was worse in South America. Manaus had a just as bad outbreak again. And I was like, okay, this is bad. Because if we can't count on natural immunity when you think the whole population has been exposed in the way that we like to, if people had had a mild illness and we didn't worry about it, right. But like, they had mass graves for the second time. Right. And those frankly behind the scenes were the two pieces of scientific data. I've read a lot of scientific data. Those were the two that made me say, ooh, if this pans out, I'm gonna be worried about it. And so I think, we have always recognized, here too, we have always recognized that there is, quote unquote, some natural immunity, always. This is why early on we said, when we didn't have a lot of vaccine, if you just had COVID, wait 3 months potentially to get your vaccine, not because you couldn't get a vaccine, because you at least had some protection, like leave the vaccine for the people who haven't had any protection yet. But this idea that I had COVID at some point in the past and I'm good is just, it's not true. It doesn't pan out. Right. Are you better than somebody who never had COVID? Yes. Is the best people who both had recovered from COVID and had vaccine the best? Yeah, that's the best we got out there. Like, I've not had COVID yet, to my knowledge, which kind of is impressive to me, given that I've never worked from home a single day and been kind of busy. I haven't had COVID yet. Honest to God, I haven't had COVID symptoms. I've tested a lot whenever I've had them. I've obviously had both my vaccines and a booster. If I get COVID at some point, I think my protection would probably be even a little better than it was with vaccines. Mm-hmm. But what worries me is people depending on that prior immunity when we know it is not as predictable, it is likely not as long lasting, and it is likely not as protective against the severe outcomes. And we're still learning about it. Mm-hmm. The recent natural immunity, I think you might be referencing the children, I'm not sure. But for example, in the the early child care guidance, there's a recognition there that kids have not had the opportunity yet to be vaccinated. And sometimes we'll see, particularly where there's testing guidance, you might say if somebody's had COVID in the last 90 days, remember, if they're getting a PCR test, that can stay positive for some time. They're not still infectious. We definitely recognize it, and you may not quarantine in a setting where somebody has recently had COVID and they've not had access to the vaccine. So I'm not sure if that's what you're referencing, but people have been trying to set up a dichotomy between vaccine and natural infection, and that's just not how immunity works.
Yeah.
It's just not how it works. They both help. We follow the serology of at the population level, how many people have been exposed to COVID. I'm really anxious to see next month's numbers. I think a lot of people in Chicago have now seen COVID in one way or another, naturally, through vaccine, both. But we're still learning what that fits into. All right. Okay, we have to be done because we're at 12:08, but I got to take this last question. Jennifer Castanon from Facebook says, why is tuberculosis vaccine not as enforced as COVID-19? I really hope you answer my question. So tuberculosis, in case you didn't know, is my favorite disease. It's the one that I initially was it's what got me into public health. I spent a year working on tuberculosis in Botswana. There is not a tuberculosis vaccine that is as effective as the COVID-19 or other vaccines are. There's this BCG, and we use it in settings where tuberculosis is high. So if you grow up in a country where there is a lot of tuberculosis, and there is a lot of tuberculosis in a lot of countries, we do give BCG vaccines. But in the US, where there is very little tuberculosis, you do the risk benefit of the vaccine, and we actually don't give the BCG vaccine routinely here. But and then this is where it gets into if somebody's higher risk, you got to test, you got to do these other things. But that's why. And in a future time, we will talk about tuberculosis maybe, because that would be great. So thank you so much. Stephanie Gretsch again, one of our senior epidemiologists at the Chicago Department of Public Health. I hope you got a sense today of some of the behind the scenes work that happens around data in public health. Hopefully a little bit of confidence or made you think differently about how we monitor COVID data. All the data that Steph showed is on our website, publicly available. We put out a weekly, how are we doing with flu in Chicago? We say we're at low, we're at high risk. We have people who call the health department every week, or they used to prior to COVID, and they'd say, is it high or low? And older people would be like, should I go to church this week? I'm not saying that is the way everybody uses this data, but there are folks right here in Chicago who look at risk for flu and use it to make decisions. And I think as we sort of work on thinking about COVID as endemic, we will be we already have based a lot of the work we do on what we know about flu. And we want to be at a point where we don't want to shut anything down. We've got a vaccine that helps protect against severe illness. And turning this into what flu looks like is in a lot of ways actually kind of the achievable goal at this point. So thank you again. I know we maybe had some tech issues in the middle there, so sorry if we lost you. I think thanks to the team here for fixing it quickly, but appreciate your patience. And we are actually probably going to take a break next week from doing the Facebook and potentially a press conference. But we will be collecting your questions. We'll be addressing them when we're back. If there's anything really acute going on, we'll be out. And then certainly the week after that, we will be back and talking hopefully about continued really good news and being able to share some exciting things.
Exciting updates about vaccine in 0 to 4-year-olds.
Maybe some exciting updates about vaccines in 0 to 4-year-olds. Maybe some exciting updates about, being at a point where we may not need to be having the vaccine requirement in high-risk settings and having the masks in indoor settings, et cetera. We are making good progress. You can be part of that progress. Please get vaccinated. I love you if you have natural immunity. I love you even more if you have natural immunity and a vaccine. And it really is just the thing that helps keep everybody the safest. And that's our goal, really, at the end of the day. Thank you again for joining. We will be back, not next week, but the week after to take more of your questions. Thanks again.